India that's today we appreciate a lot that's join us. Please, Nuti, all yours.
Thank you, George. Thank you, George, and thanks for including All India Ophthalmic Society, which we all represent, and Vitreoretinal Society. We have Dr. Anand Rajendran as the scientific chair, and Dr. Shobhit Chawla as the president, and Dr. Natarajan, who's also there as the secretary. And I'd like to introduce Dr. Vishal Agrawal, young, dynamic vitreoretinal surgeon, did his fellowship from Shankaranayatala, my alma mater in Madras, and then he's a professor in the SMS Medical College, Jaipur, and he won here, and plus he's also won several awards on vitreoretinal surgery. And over to you, Vishal.
Thank you, sir, for the kind words. And I request
who's also there
to start my video. I have already uploaded
I'd like
the
to
video.
introduce Dr. Vishal Agrawal, young, dynamic vitreoretinal surgeon, did his fellowship from Shankaranayatala, my alma mater in Madras, and then he's a professor in the SMS Medical College, Jaipur, and he won.
This case is of a 65-year-old female
Here,
pathological
and he's
myopia
also won several awards on vitreoretinal surgery.
with posterior
And over
pole
to you, Vishal.
Thank you, sir, for the kind words.
This animation
And I request
how to manage
also there
to start my video. I have
and
already
long
I'd like to
video
introduce
from my
in order
Vishal
for our
Agrawal,
instruments
young,
to reach the
dynamic
macula
vitreoretinal surgeon,
in these
did his
myopic
fellowship
eyes.
from Shankaranayatala,
Can you please
my
start
alma mater
sharing
in
my-
Madras, and then he's a professor in
Thank you.
the
As there is always a
SMS
presence
Medical
of
College,
vitreous
Jaipur,
having multiple
he
staining
won.
has to be done with This case is of a
preservative-free
65-year-old female
Triamcinolone
trypan blue and brilliant blue G. After PVT induction and adequate macular staining, a small amount of PFCL is injected over the posterior pole. This gives counter traction in cases where there is a lot of fluid at the macula. ILM is then peeled using the pinch and peel technique. The important point here is to remember that the peeling should be wide enough till the edge of the staphyloma curvature to make the retina adequately redundant. Layered inverted ILM flap to cover the macular hole. In the end, PFCL is slowly aspirated, taking care not to dislodge the flap. The advantage of this technique is flap is very stable under the PFCL bubble and there is no need to make an additional retinotomy for drainage.
So this is a standard technique we follow, and sometimes you have the subretinal dye inside. You can always aspirate that with a small amount of PFCL over the retina, and that helps to flatten the posterior pole. And then you can safely inject a small amount of PFCL over the posterior pole. And this is a standard technique which we follow in these cases, and giving us excellent results with type 1 closure in almost every case. The important point here is to identify the ILM, and once it's folded initially, have a wide angle of peel till the edge of the staphyloma. You can see the fluid has been displaced because of the PFCL in the periphery, but you don't have to drain that fluid with the additional retinotomy. You just close the hole, with multiple flaps of ILM stuffed over the macular hole, and just leave it there. And in the next post-op day, you can see a flat macula. You don't have to drain it at all. So this is a very stable and reproducible technique of doing these cases. Of course, you have to make the ports at 5 mm so that the instruments can reach in these high myopic eyes to the posterior pole. After doing that, you go under air and you gently aspirate the fluid. So the beauty of this technique is once you have tucked that ILM flap into the hole, the flap does not get displaced. So you always have a look at that blue PFCL. You can see the flap is still in place, and this is the post-operative pictures, and we injected C3F8 and the patient did fine. So this was my case, and thank you RWC and DRSI for having me here to present this case. Thank you so much.
Very nice, great talk, great video. And now I'll ask my friend from India Vitreoretinal Society, Ananda Rajendra, please start with the discussion and we're gonna have a good time.
Yeah. So a wonderful video as usual, Vishal, an excellent technique, excellent animation, excellent graphics. I think this is a very pertinent point that you've raised. I think the use of PFCL, especially in this kind of a situation where you have a myopic macular hole with with this detachment around it, the PFCL helps in two reasons. One, I think it tamponades it down the detachment, and it allows you when the BBG is in, greater counter traction when you're peeling that ILM. Actually, counter to what intuition tells you, it actually makes the ILM less friable and it tends to come off a little more easily. And I think I liked that point which you made, that try not to detach that ILM, break it up piecemeal, so that you have a continuous curve and you have that cabbage flapping, if you want to call it that way, or the multi-layering in. So I think that is important. Also, the PFCL and that contrast with the BBG gives you helps in, because it's more difficult to view the ILM in such cases. So I think that's a wonderful technique, wonderful execution of technique. And I just like to ask my colleagues from other places, Dr. Tariq Hassan, what is your take on this?
I think that was a beautiful technique and a beautiful video, and thank you for showing it to us. These cases are obviously not easy cases to do, and they are a much higher rate of recurrence or failure to close that hole. So your technique is wonderful about creating that bridge, and I like how you were able to keep the ILM together, and it takes the issue of wondering about whether you push the ILM flap in or not. You take all of that away by using the PFCL. You flatten the macula basically, and I take it you're sort of leaving that thing attached and placing it there rather than manipulating the subretinal space in that region. So I think that's terrific. Can you tell us, you also used triamcinolone staining as well, is that right?
Yes, sir. Triamcinolone is used, basically, as I mentioned in the video, vitreoretinal is universally present in such high myopic cases. And even if it is apparent to you that PVD is present, actually, if you stain it, multiple times, you will find a thin sheet of cortical vitreous over the retina. And if you don't remove it, actually, you won't, stain the ILM properly. Anyways, in this, the contrast is poor, so you need a good staining of the ILM. So without removing the whole cortical vitreous, you won't get a staining.
Yeah, so I love that idea. I think that using multiple stains dynamically like that to identify the different layers that you need to address is great. I mean, I think that's the most important thing to prevent this thing from failing.
The second part is that the area of the ILM peel, if it's small, you might get a good closure in the post-operative period, but there is a lot of recurrences. So the crux here is to have a wide angle peel till the edge of the staphyloma. Adequately redundant, then it will not recur. So the area of the peel should be large.
Yeah, I think that's important in these kind of cases.
Vishal.
Just one thing, anyone from the speakers or anyone from the panel can jump in the discussion anytime.
Yeah. Can I just add something?
For everyone. Jean-Paul want to say something.
Yes. I just want to say just how useful the use of PFCL is in this case, because it also gives having iatrogenic tears, because this retina being less mobile, you reduce the risk of that. But I did want to ask you a question. When you're removing the PFCL, what are your settings with the intraocular pressure? Because I would presume I generally don't. Well, I have low settings because I don't want to displace the flap, but I do not use PFCL in certain cases, so I must use obviously low settings. Do you also use low intraocular pressure settings to remove the PFCL, or is that not an issue?
So when I'm injecting the PFCL, normally
when you're removing it.
While I'm removing it, it's almost 20 to 25 mmHg of mercury, and I remove the PFCL with passive aspiration. I do not use the cutter or an active aspiration.
Yes.
So that gives me a more better control.
Exactly.
And I always
agree on that.
The nasal side. Yeah. So even if the flap displaces, the flap comes over the hole.
Exactly. But what is your setting? So is it low intraocular pressure that you're using? Low
it's 20
infusion?
of mercury.
20. Okay. I go as low as 10. So to have better control, but yeah, I totally agree. Yeah, so you do it nasally, and that's important because if it does displace, you will get it over the hole anyway. Yeah. Okay. Good point. Thank you. Wonderful video. Thank you.
I think Sangeet Mittal raised his hand, George. Sangeet.
Yeah. Thank you, sir. Discusses. when we are starting the peeling in these cases, I would like to prefer it without the PFCL. Initiate the peel without the PFCL. One thing is like the detached retina, because it is raised, it gives you an extra. Your instruments reach the retina easily. Sometimes when you flatten the retina because of the high myopia and the posterior staphyloма, your instruments, despite having a posterior sclerotomy, are not able to reach the retinal surface easily. So keep the retina detached. Initiate the peeling with the detached retina, then put PFCL, and then you can fold the flaps over the whole. I think that is a better thing. And one more thing is, like, I personally prefer to use ICG in these cases because of the better contrast. The ICG get a better contrast. Thank you.
I think Tatiana has
normally what in the routine macular holes, I just have the brilliant blue G for 15 to 20 seconds, but in these cases I keep it for a well 45 to 50 seconds, and that gives a excellent contrast. So for a 15-20 second duration in routine macular holes, this does not work in these cases. So you have to keep the dye a little longer.
Yeah, Tatiana has her hand up.
Yeah. Thank you. That's how great surgery. The surgery is very challenging always. Could I ask you, do you have experience with temporal flap, not completely removal, or it's a key point to remove the ILM completely to remove traction convention?
So okay, so the point in temporal flap is that works beautifully and it's a minimally invasive surgery. But the thing I've seen in temporal flaps is with time, in the serial OCTs, you see a thinning of the flap and thinning of it's a type 1 closure, but you get a macular thinning. So the whole point of multiple flaps is that the normal contour of the macula is maintained even a year or 2 years afterward, after surgery. So it does not thin out. So gradually, if you have a single flap of the hole, it works, but it thins out in the post-operative period. Multiple flaps does not thin out. So it maintains the vision, it maintains the normal macular contour.
Yeah, and if I might jump in, temporal flap works very well for a regular macular hole. But this is a special situation where the hole is almost in a staphyloma. So what you're really trying to do here is to remove the tangential traction 360 degrees. So it's not just important in this specific scenario to remove the 360 degree ILM, but also do it, as Vishal mentioned, to do it fairly widely. So you try to reach at least as far as you can towards the edge of the staphyloma, if possible. If it's not possible, of course, that's different. And also to address what Sangeet mentioned about ICG. I don't use ICG because I believe it's toxic to the RP. And in this situation where the choroid and the RP, everything is much thinner, the chance of toxicity is that much more. Also, secondly, when you use PFCL and BBG, the contrast is tremendously enhanced because there's BBG stuck under the interface layer and therefore enhances the contrast. So you see actually much better when you do it with PFCL. So I agree. And I'd like to ask Dr. Mauricio, he's got his hand up too. Your impression.
Yes.
Mauricio.
Actually, I would like to congratulate for the surgery. I believe the use the triamcinolone to see better remnants of the hyaloid, because this case has a lot of traction and hyaloidosthesis. This is very common. I think it's fundamental for these cases. And about the ILM, actually, I tried many different techniques. It's good when we can, as our colleague told before, do it without perfluorocarbon, okay, and using the brilliant blue. However, sometimes this is not easy, and you may start the peeling is not so easy. So I believe when the instrument is able, and we do posterior sclerotomies, and the instrument is able to reach the posterior pole, to do it under perfluorocarbon, at least in my hands, are easy. It's an easy surgical procedure.
Thank you. I think we have the next presentation, and I kindly ask my friend Gianpaolo to introduce Tatiana. Tatiana, you are very welcome here. You are the first representative from Russia, the great country. We just got many greetings for friends and colleagues from Russia right now in my WhatsApp. Thank you all for being with us. Please, Gianpaolo.
Thank you very much. First of all, I would like to thank for this invitation. It's a great honor for me to take part in today's meeting.
Thank you, Tatiana. We're very happy to have you here. Tatiana is a treasured member of EVRS. She always brings us wonderful videos and a lot of experiences from her everyday OR. And today, I think she's going to be talking about vitrectomy for massive subretinal hemorrhage. Is that correct, Tatiana?
Yes.
Yes, please proceed. Thank you.
Thank you. My presentation is about surgery of massive subretinal hemorrhage. Like all of us, we are quite successful in treating small submacular hemorrhages by vitrectomy and subretinal injection of TPA and air tamponade as soon as possible. But if we don't have free space for displacement, the hemorrhage, we need to do something more else. And so the decision may be the evacuation mechanically with blood. So I would like to present you my case. This is the female, 70-year-old. She had neovascular AMD, and she also was on anticoagulant therapy. So we started with phaco and higher implantation, and then continued with COVID absence. Cortical vitreal, the triamcinolone was injected. After that, we inject bubble of PFCL to flatten the central part of retina, and retinotomy about 200 degrees was performed. The visualization was poor due to liquid part of hemorrhage. The retina was folded over, and I put silicone, or I put PFCL and continued working under the PFCL. The clot was displaced and their sclera became visible. I continued with removing clot, and most of the clot was removed by vitrectomy. But final part was like a stone, was too hard, so I decided to remove it through the window of posterior capsule and corneal incision. After that, complete filling PFCL and oil tamponade. This is the picture of this patient, 1 month follow-up. She was happy in spite of the low visual acuity. It was something like hand movement or counting fingers in 10 centimeters. But she had PFCL under the macula, and geographic atrophy was the main reason of low vision, of course. In 2 months, we went to second surgery. At first, the proliferated tissue was removed, and after that, I decided to displace this PFCL bubble. Of course, I was into the eye and decided to help increase visual acuity. Add some laser and finished with 2 weeks follow-up. We can see the PFCL in the lower part, and this is the picture before and now. She was also happy because she had field of vision was bigger, and visual acuity was also better. It's hard to measure it, but she was happy to do these changes. And here are some more cases of relationship between anticoagulant medication and age-related macular degeneration with massive intraocular hemorrhage. And one more. And in conclusion, we know many publications about association of hemorrhage in AMD patients on anticoagulant therapy, but it was before COVID times. And I have a subjective assessment that the incidence of submacular hemorrhage are now on the rise due to maybe more frequent or possibly high doses of prescribing anticoagulants medication. And I think now in these times, there are dilemma like never before between bleeding and thrombosis when anticoagulants and antiplatelet agents are used for cardiovascular disease cases. Thank you for your attention.
Great presentation, Tatiana. Beautiful videos. Gianpaolo, have you seen some case like this with the new generation of anticoagulants in UK, and what do you think this approach?
We have massive hemorrhages like these, and the approach is for these massive hemorrhages, what Tatiana has described, generally a retinotomy beneath the retina. I'm not quite sure that we would use PFCL. I know why she did it. She did it to control the bleeding, but we would not really be using PFCL underneath the retina. Basically, it's because we always tried to avoid that in the past, but it could be, she showed that she only had a bit left, and I don't think that really affected the patient's visual acuity, because the main reason the patient had low visual acuity is obviously the underlying disease and the RPE atrophy. So essentially, I think we go back to what we have been doing in the past for these massive hemorrhages, just removing them with a large retinotomy.
Good. Dr. Ananda, how you handle this case in India?
Yeah, I think very elegantly done. I think the important thing is to make that retinectomy wide in the periphery, so you are not affecting central vision, and then flipping the entire thing over. It's a massive amount of hemorrhage, and I feel tissue plasminogen activator, if given in time, probably helps liquefying. And I agree that, PFCL down there, I can understand that you might have felt the need to control, get a grip, get a handle on the bleed with PFCL, but invariably PFCL doesn't actually help as much as intraocular tamponading helps. And I understand that, you might have felt that. It is difficult to remove it. Sometimes that clot can be very leathery. In fact, I've actually had occasions where I've actually had to go in with the scissors and cut the clot into different, aspects. And then it's almost like removing a piece of nucleus, and you actually have to remove one part by yourself. So I think that is there. And the danger of, using PFCL under the retina is this retained PFCL under the retina, which you had a bit, and then you managed that very well. So I think that is there. Some people, not for such massive ones, but some people have also considered an interesting cocktail of air, anti-VEGF, and TPA. So some people have done that, liquefied it, and then gone back and done it. So I just like to hear the opinion of the panelists with that angle. So Dr. Gianpaolo, Dr. Tarek, what do you your take on that?
We tend to use that cocktail as you quite rightly describe it. We use it routinely, but for smaller hemorrhages, to displace the smaller hemorrhages. So we do that on a regular basis. Actually, to be honest, we don't even do a vitrectomy in those cases, which I'm not quite sure whether or not is the proper approach, but this is the tendency here. But for those very large hemorrhages, obviously, I don't think they would work in any way. And the only approach is to displace it. Another way you can control the bleeding, of course, is with air. If you use air instead of PFCL, the air will stop the bleeding, and then you can proceed with the removal of the clot itself. Another point you made, which I totally agree on, is that you have to be very peripheral, because if you are not peripheral enough, and we know this from our old macular translocation operations, you will get PVR. So you want to be peripheral with the retina doesn't have as much vascularization, and therefore the incidence of PVR would be much smaller.
Very good. Mauricio, my friend from Brazil, what do you think and how you handle the PFO underneath the fovea?
Actually, I think, George, the most important thing in this case that I would like to make some comment, and I congratulate our colleague Tatiana. This is a wonderful case. And I believe massive hemorrhage, especially in monocular patients, for these cases, this is a very important surgical technique that may change the life of this patient. So I would just like to say that the PFO removal was okay. I think what I think is the message important for people who are watching us is we need to avoid PVR, because sometimes if you do that, the PVR and redetachments may cause more problems than the solution that you did in this wonderful surgery. And to avoid that, I think it's very important to avoid high turbulence of BSS inside the eye, to avoid our RPE spread into the vitreous cavity, and also to avoid bleeding during the surgery. So these are my messages in this case. Thanks a lot, George, and congratulations.
Thank you. Dr. Ajaz, please.
Yeah, very nice. Very nice presentation and excellent case by Dr. Tatiana. Some cases we have these massive subretinal hemorrhage, especially in patients with polypoidal choroidal vasculopathy. They have, as Anand was mentioning, a very thick clot. They get dehemoglobinized. Instead of red blood, they become yellowish, brown, ochre colored, and they are not easy to remove. So one technique which we use in such massive subretinal hemorrhage is to inject subretinal TPA, not in the traditional quantities which have been described, but you inject slightly larger quantity, but wait for about 20-25 minutes in the OR. Once you inject, you have to wait, pass your time. Then after 20-25 minutes, when the clot liquefies a little bit, the surgery becomes easier. And then obviously, the retinotomy which you have mentioned, you have to make, that is something which we do sometimes in extremely clotted, thick blood. So the regular subretinal TPA doses don't work in those cases. The other thing is, while you mentioned the limited visual recovery, that's because of the inherent macular pathology. But I have seen post-trauma subretinal hemorrhage, very massive, which have been handled like you have shown, Dr. Tatiana, but they recover excellent vision because the macula was not that badly affected by any disease. So I think it's mainly the disease pathology which is limiting the visual acuity. But again, excellent case that you have shown.
Dr. Raja.
I put a TPA in my third case without any PXL under the retina. It's really easier to remove.
Concentration of the TPA you suggest, because you said you use a lot of TPA. The paper said that you should not exceed 50 micrograms underneath the retina, not to be toxic.
Yes, so typically we use about, let's say, 25 micrograms to be on the safer side. But in such massive subretinal hemorrhage, it's not enough to inject in one place or even a couple of places. You have to inject in 2 or 3 locations. So I've even gone up to 75 micrograms. But we do remove that, completely remove and drain it, so that it's not a long-standing, TPA that you are injecting. But you may have to go even up to 75 micrograms.
Okay, just because you drain everything, the concentration will not stand there for a long time. Just because this you can use more than 50. Understand?
Yeah, and it's also important to remove these clots as much as possible, because post-operatively, I've seen quite a few patients who get breakthrough vitreous hemorrhage. Even otherwise, when they get breakthrough vitreous hemorrhage, the blood comes into the anterior chamber and again becomes a mess. You have to go in again. You must try to remove as much as possible when you are in the first time.
Okay, thank you very much, Tatiana. Beautiful case. We learned a lot. And now we're gonna move on. Nuti, you wanna introduce Dr. Nishikant?
I will do that. Nishikant actually was trained in Shankar Nethralaya, and then he's practicing as a vitreoretinal surgeon in Mumbai. He was a faculty with me. We are proud of him. He's a fellow of ASRS, Forlini Award from EVRS, CS Rashmi Award from AOS, and JM Pava Award from Vitreoretinal Society of India, and Best Video in the VRSI. And we have multiple presentation and publication. And apart from that, he's an excellent, gifted vitreoretinal surgeon. Over to you.
Thank you, Dr. Natarajan, for the kind introduction. And thank you, RWC, for inviting me. Thank you to iOS and, of course, VRSI for giving me this opportunity. Can I please ask the admin to share my video, please?
Due to the limitations of medical therapies, vitrectomy promises to be a potential treatment option for central retinal artery occlusion. Here we present a novel surgical technique for dislodging the embolus using a combination of low IOP vitrectomy, disc dissection, and arterial massage, which helps in dislodging the embolus causing the CREO. First step is to perform a low IOP vitrectomy. It reduces the resistance offered by the intraocular pressure to the ocular perfusion from the central retinal artery. The disc dissection is basically a de-roofing of the disc by dissecting the central disc meniscus. This helps in decompressing the retinal vessels as they emerge from the lamina cribrosa. This de-roofing of the optic disc and massage of the central retinal artery from center to periphery in a radial fashion, along with an arterial sheathotomy, helps in dislodging the causative embolus from the central retinal artery. Let us see a few of such cases. In this 32-year-old gentleman with CREO, the conventional treatment had failed. After performing the vitrectomy, one can see a part of the embolus being dislodged to the periphery. As the central retinal artery starts pulsating at the lamina, the rest of the embolus can be easily located and massaged out to the periphery. He did very well to regain 20/200 vision. Central retinal artery occlusion following a mitral valve surgery posed a challenge as the embolus was large and had to be literally milked to the periphery. Again, once the central retinal artery starts pulsating at the laminar area, the rest of the embolus is easily dislodged. The migration of the embolus is dependent on the mean arterial pressure. The embolus may many times break into multiple pieces in many cases. We feel that if the embolus is around the area where the central retinal artery pierces the dura, the surgery is not likely to be successful. Dislodging a deeply located embolus represents a limitation of this procedure. However, if the occlusion is at the lamina, the surgery stands a good chance of success.
Congratulations. Very beautiful indeed. I love the video and the dislodge of all the clog. That's beautiful. But I have so many questions, but I leave with my friend Ananda. He's the
So as usual, we've seen this video a good number of times in the Indian retinal conferences, and Nishikant is an absolute pioneer in, championing this particular kind of surgery. There's been a lot of debate about it, and we can do that in this session too. But my question to Nishikant is, what are the key steps that you would identify? I think you mentioned hypotony and, case selection, and how soon or how late a case would benefit from this surgery, and any other things that you would recommend, cases where it didn't work out, also people would like to know. So over to you, Nishikant, and fabulous surgery as usual.
Thank you, Anand. So the key out here is time. Most of the times, patients don't come to you on time. I mean, they have come to you after 3 to 4 days or 5 days or even 10 days after that. And even if you manage to dislodge the embolus, the retina is not going to live. So it's really futile exercise. So it just adds to your ego that you could dislodge the embolus, but it really didn't work well for the patient. So it's really futile. So time is the most important thing. The second thing during the surgery is hypotony. So many times, you're inducing the PVD and your globe will collapse. So don't go back and increase the IOP just because you feel the globe is collapsing, because that's the most important key. Because when you are having hypotony, that's the time the thrombosis or the embolus is actually migrating away from the lamina into the eye. That's where the least resistance comes in. And then you have to keep on observing for the pulsation of the central retinal artery. And once the CRA really starts pulsating, even in that hypotenuse eye, that's the time that the embolus is just around the corner for you to dislodge it. Now, in case selection, you can make out there are certain cases where they just come in with very pale, just pale, and the retina is so pale, the arteries are totally occluded. Tight CRAO, and in such cases, again, your surgery is not going to work. The biggest challenge is how to differentiate whether it is a deep laminar block or the blockage at the lamina fibrosa. Sometimes maybe you do an FA and you can make out there is some amount of residual circulation which gives you sort of a clue to that, or your vision which is not just about PL, maybe finger counting or counting fingers close to face. Yes, it does work. To add, I had about 2 cases in whom I could manage to do within 6 hours of occlusion. And one is an anesthesiologist, got back 20/20 vision, and the second one got about 20/40 partial. So time is the essence and the key, and it does work it that way.
Absolutely. Absolutely.
Thank you.
Dr. Tarak, I think you have a question.
Yeah, I find that a fascinating video, and so that I really congratulate you on presenting something so interesting and striking. To see the embolus traveling downstream like that is really quite impressive to see. When you're peeling or unroofing the vasculature in the disc or at the area of the lamina, are you removing what you feel to be the adventitial sheath of the artery, or do you feel that is a vitally important part of the procedure, or is it more the hypotony induced by the vitrectomy? Where do you think that the relative value of peeling whatever that tissue is in the center of the area over the vessels is? How important is that part?
Right. So I have done an OCT many times before we go in for the surgery. And in about of my 38 cases that I've done, about 8 I've seen some amount of fibrous or adventitial tissue which is lying right on the top of the disc where the artery is emerging. And in this case, it's of most important for us to remove that tissue, because the minute you relieve that tissue, the sort of a pressure on the artery goes and it sort of opens up. The second thing is hypotony is crucial, but when the artery starts pulsating at the lamina, that's the time you have to start massaging the artery and sort of doing a radial fashion massage and sheathotomy, so to help actually dislodge the embolus from where it is stuck, where the artery literally is at 90 degrees when it emerges from the lamina, and that's where you need to really dislodge the embolus. And once it crosses the edge of the disc, it just goes away. It doesn't stop there. So that's the crucial point.
So nice case, Nishikant, as usual. Following up on Tariq Hassan's question, what which you have operated so far, have you seen any dislodgement of embolus? Because I have tried a few cases, I didn't see even the glial tissue or adventitial tissue. I tried a lot, maybe stain, and then still I didn't find any tissue. But in spite of whether the tissue is visible or not, whether you remove it or not, what percentage of your cases were you actually able to see a dislodgement of the embolus?
So out of the 38, so that's the exact figure that 33% of the people have got a visual acuity of better than 6 by 636 or 624. So that's how it is.
So
Unfortunately,
irrespective of the, sorry, go ahead.
Yeah, so like I said, time is the most essential. If the patients come to you late, you're definitely not going to get it.
So irrespective of whether you see a dislodgement of the embolus, you think this surgery works, even if, because you said in only 8 cases you saw an embolus coming off, but even without any dislodgement, you saw improvement in the visual acuity. Is that right?
Yeah. So like I told you, sometimes the dislodgement is so fast, you really can't see. I wish I could present that video too. So post-cataract surgery, the patient was operated for cataract in the morning, and by evening he was vision was down to PL, and he had a central retinal artery occlusion. And in him, when we did the vitrectomy, the CRO just opened up intraoperatively, and the patient got back 624 after a couple of days. But in that case, how much ever I tried, I really couldn't. Even I tried to freeze the video and try to see if the embolus has gone by really fast, but I just couldn't see. So sometimes, it's just like it becomes like a sludge, and you really cannot see them that way.
May I say something on that?
For sure.
Well, great technique and a huge number of patients, and I'm sure that in India you've got much more patients that we've got in Greece. And the thing is that behind when we started doing vessel surgery in the old days, it was a
from the new generation of brilliant retina specialists in Brazil, Carlos Moreira Jr. from Paraná. He's from the south of Brazil. He works one of the largest eye hospital in the south of Brazil.
Hello, everyone. Thank you so much, my friend. Thank you for RWC for the invitation. And it's a pleasure being here today to present this case, extensive subretinal fibrosis, and an unusual presentation in diabetic retinopathy. So this is a male patient, 68-year-old, with a bad control on his type 2 diabetes. He already lost his right eye due to diabetic retinopathy, and the visual acuity on his left eye was counting fingers at presentation. This is the baseline OCT, which clearly shows a retinal detachment, and here is the surgery. We start doing posterior highlight removal. Then we saw this pre-retinal fibrosis. We decided to do a bimanual technique to perform a complete removal of this fibrosis. Then we saw that there is a retinal tear. We tried to reattach the retina with no success because there was this huge subretinal fibrosis, as you can see. And here is my first question. How far should we go? Should we have a complete or a partial removal? As you can see, we start pulling it and there was an enlargement of the retinal tear. So we decided to do a partial removal. Now you're going to see that. And then the retina could be reattached. PRP was done. And then in the end, silicone oil was injected. Here is the eye 60 days after surgery, a better vision, 2400. Retina is completely reattached. The most recent OCT shows a macula on. However, we barely defined the ellipsoid zone, what could be a limitation on the vision. And I would like to bring 3 points that we should discuss. How frequent you guys already seen subretinal fibrosis in diabetic retinopathy? Should we perform a partial or a complete removal of the fibrosis? And who would consider scleral buckle in this case? Thank you.
Thank you very much. Brilliant video. I'd like to start with Mauricio.
Yes. Actually, I think these cases are very complex and depends on the situation if you're going to do a partial or complete removal. When you find difficulties during the surgery to remove all the traction, the subretinal fibrotic tissue, and actually you just remove the traction, maybe is enough in order to avoid massive subretinal bleeding and something like that may result in a bad outcome of the case. I think this was the case. I will do the same surgery, and actually, I don't know if buckle was actually necessary in this case, because I think it was. It's not very periphery, you know. Actually, what I like to do in these cases that I'm afraid of PVR is to use heavy silicone oil for inferior pathologies when I have, you know, I'm not able to, I'm not sure if the PVR will come. Then I suggest the heavy silicone oil. However, I just go to buckle if I'm not able to remove the vitreous base nicely. I think these should be my approaches for your questions. So wonderful surgery, and thanks for sharing with us.
Paulo, want to say something?
Yes. Congratulations. Beautiful video. Beautiful surgery. Yes, to try and answer your three questions. So, how often do we find them? Well, not very often, really. I think here the fibrosis is due to the fact that this was a long-standing shallow detachment. Essentially, it depends on your screening service, really, and how quickly you get these patients into surgery. Regarding how far you should go to remove the subretinal fibrosis, again, I agree with Marcelo. You go as far as needed, really. If you can get the retina fat on the air, and you don't need to go into extreme removal of the membranes and to risk bleeding and retinal tears. The buccal, I don't really see a use for the buccal here because I think most of your fibrosis was located at the posterior pole mostly. Correct me if I'm wrong. And I don't really see a use for the buccal in this specific case. Other cases, yes, but not particularly here.
Thank you. Ananda?
Yeah, I think you brought up an important point with this surgery. First of all, congratulations, you were able to achieve, great anatomical success. One thing is, when you're faced with this kind of massive subretinal fibrosis peripherally, what you can do is, once you make that retinotomy and start pulling out, do what, Dr. Giampaolo talked about, that noodle technique, try to, spin it around on that forceps, and then very often you will find it coming off completely. If it does not, even if it breaks in certain places, that's almost good enough. Sometimes yanking it when there's too much of resistance, you get this chance, there's risk of causing a widespread tear, and that can be linearly, radially, as well as circumferentially. So that's a risk. So you'll have to judge. That's a tug feel that you get when you're doing it. Comes with experience. Another option is, you can actually, if you look very carefully, you can actually, trace the entire extent of that subretinal peripheral fibrosis, and you can actually make small retinotomies at different points and break that little bit of, peripheral napkin, and you can break it up into small parts, and that way you have less trauma going around. You don't have a massive retinectomy going all around, and you can break it up and piecemeal pull off some amounts, and then you can use your subretinal forceps, which has a long flange underneath, and you can go underneath and you can just pull it off. Ultimately, you can also use in PFCL, and that will give you a test. If you don't have a clothesline kind of effect, if you find the retina smoothly settling down, then I think you're comfortable.
Perfect. Agreed.
Do you feel that air could be more useful than PFCL, because PFCL sometimes fools you into seeing things that actually will not settle down once you have removed it?
Yeah, but what I feel is, with PFCL
as a test.
You can, as a test also. I feel with PFCL, while you're testing, you can at that same very point of time, you can use the forceps to pull it off under PFCL, and your retina is stable at that point, rather than, and also the visibility also helps, rather than having air coming in from above. Sometimes that can help.
You can also segment. You can also, as we pointed out, segment these membranes without removing them.
Yeah.
You can
segment the whole thing, segment it.
Yeah, you just segment and the traction is gone. Yeah.
Yep.
Dr. Haja? Dr. Haja, not here. For me, I think this. I just found this subretinal fibrosis when they have a combined fractional and rhegmatogenous detachment, and really chronic diabetic case, very bad. Not just because the subretinal fibrosis, but because the retina is so ischemic, and even when you start to pull the subretinal fibrosis, and the retina is so fragile, that's gonna enlarge the hole very easy and it's dangerous. I had one case very bad, something like 3 months ago, and the result was not so good. You did a very good job, and I think that we don't need the band just because the the traction is mostly in the posterior pole. If you release some traction and as Gianpaolo said, use the air to test if the retina is going down and attack, it's okay, just finish. But thank you very much. I think we approach to the end, and now we're gonna have for the first time a great name in the retina from Greece, Dr. Athanasiou, and I'd like to ask kindly my friend Gianpaolo to introduce this great personality.
Well, introducing Athanasiou for his friends is not an easy task, because he's really been a world leader in this specialty, and he's well recognized as such. He teaches on a regular basis. He, as most Europeans, and not only Europeans, know, he has his own school in Greece, and I think a lot of surgeons have come out of it. He has been with EVRS since its foundation. So what can we say? He is really a pioneer in this field. I don't want to say that he's senior, but he is, at least as far as surgery is concerned. He has a lot of experience. We can only learn from what he has to say. So, Athanasiou, would you like to present your work, please?
A word about Athanasiou, and Athanasiou and me are great friends, along with Cesare, with Dr. Relja Jovanovic. So you can tell the time zone. We are friends.
It is very nice. It is very, very nice to see you all. I mean, it's like being in an old club again. And can you see my PowerPoint? Is it okay?
We can see you.
We can't see.
You can see it?
Yeah, we can't see.
Well, share your screen.
Okay, let me go back again. Let me go back. Let me share my screen. And then I'm going to share.
Okay.
Okay.
I'm going to use this.
We have you. Okay.
And then stop. We're going to have this.
We see you. Okay. Thank you, Athanasiou.
First of all, I need a couple of minutes just to say a few things. I would like to congratulate Tarek Hassan for starting where he started and becoming the leader of education in Retina today. And I really appreciate his work all these years. And that's extraordinary that we're together after so many years again. And of course, with Paolo Gini and Natarajan and all these very old people, we were together for many years in many places. And in the old days, we used to have something that they called meetings. Some of you remember that we get all together and we have a 10-minute presentation and 24 hours fun. And I'm missing the fun. I'm not missing the presentations. The presentation that I showed today almost made me think that I have to stop doing surgery. If I see such young, brilliant surgeons doing anything that in the old days we see this extreme surgery. And so I'm going back to my presentation, and that's it, because I want to present something that everybody has, but they don't have a name. They didn't group it until now, and we tried to group it, and it's good for the fellows, not for the extreme surgeons that you showed it before. So no more extreme surgery. Let's go back to normal things. What we call that? Well, the vitreous base is something that we have to consider, all of us, that it's a very important issue because that the collagen is not the same, and it's extremely difficult to remove it. And these fibers are very difficult to share during surgery. So when they say they remove the vitreous base, it's truly something exaggerating. And the problem is they extend radially toward the vitreous gel for several millimeters. I'm not going so much to the anatomy. I'm going just to show you a picture that it shows where the vitreous base is supposed to be in normal eyes. What about when the vitreous base is not where it's supposed to be? Posteriorly inserted vitreous base was defined in the sense of posterior hyoid membrane being located posterior to the vortex vein. And that is not a very old presentation. Average numbers of tears seen postoperatively in this area of posterior, it's 3 to 1, 30% of new breaks identified intraoperatively. That means that you don't see them before. Average distance of the oral serrata to the vortex vein is 7.6 millimeters. So adjunctive buckle was used in most cases. Redetachment and proliferative, this is important, vitreoretinopathy still occur despite knowledge of the disorder and adjuvant treatment. That means that you have to know when you see a case that I'm going to show you, you have to be very extra careful because they tend to go to PVR much usually. So what is exactly what I'm talking about, zipper syndrome? Multiple tears in one meridian in a retinal detachment without PVR. Every tear is in the same plane, also in an attached retina. So you can see tears in detached and attached retina, as you can see. And the posterior base insertion is back. So gives the impression of a continuity that acts like a zipper that given time can open all of them and produce a giant tear. So it's one after the other in a line of a zipper time because of the traction of the posterior displacement. You can see in this video, while I was doing laser in one case like that, I'm on a flat retina now. I'm doing laser on tears, on multiple tears. You can see this here. You can see another tear here, another tear here, and they're just bridging a little bit from each other. And there's a next one here. And this is attached retina in a detached eye. And so you see here is the detachment, how anomalous is the tear of the detachment. And I used to drain the detachment from the tear directly. I don't use perfluorocarbon in these cases. I just drain it and it becomes flat. And then when I'm training with the fluid needle under mechanical drainage, not using, and then I do the laser. So you can see the line. This is the important of this video. You can see the line of laser. It's exactly in the same meridian all around. So that every tear in detached and attached retina are the same. Surgical results consideration is that the vitreous saving much more difficult and traction should be removed from all the tears. When you do a vitrectomy, you cannot leave with traction in one tear and leave and remove every tear. So it's very difficult to remove all the traction from all the tears. And they have a higher detachment rate due to a tear opening. So this is the video that it shows how it looks when we found a video with a posterior displacement. So if I can, it's a normal flat, fresh vitrectomy that we do in a retinal detachment. And you can see the detachment. It's going nicely in a detached area. And we do the complete vitrectomy in all cases. And I have a thing that I'm doing always. I'm doing first complete vitrectomy in an area that there is no detachment first, when it is a semi-detached thing. And then I go to the detachment area in order not to remove the fluid of the back of the eye. And I would like, there it is. You see this here? Can you check it here? Here is the vitreous base and where all the traction is. And I'm trying to remove it. Look at that. I'm trying to cut it. I'm slowing down the cutting rate. I'm increasing to 650, and I'm engaging this membrane here that is almost at the equator. And nothing is not coming off. You see how clearly it shows? It's vitreous attached to the retina. And it's at the equator. So if that's one of the very seldom videos. We got some cases. We don't care about how many, we don't care about statistics here, that all of them give the impression of an incomplete giant hair. This is the thing. So what is the difference between recognizing a zipper syndrome or not, a vitreous-based displacement? It's not a simple primary vitrectomy. You have to do almost 360 laser. And then there is possibly another buccal indication. So a 360 circumferential buccal that is going to be in the same area, the same equator, it's going to be very helpful in these cases. It needs vitrectomy and buccal for these cases. So you minimize, and probably the gas air exchange should be C3F8 in order to keep the eye in a better position. And as our great teacher used to say, progress comes from doing the unconventional, where I saw exactly what people were doing before me in this beautiful presentation they had. That's why with my late friend Cesare Follini, we tried to organize something to train people of how to face things in the new technology era, because technology, what it is, it brings us a lot of things, and they say, now use them, and there is no practice for them using the latest technology. Everybody cannot have the latest technology. So we made a school. Every year we do it in the summer for a week in Thessaloniki, in Greece. And if anybody wants to look at it, it's tvrs.gr. And we do it together with the great Cesare Forlini, that I'm sure I'm mentioning him every time I have to talk, because I think he was the greatest person and the only one in the world that has no enemy but only friends, and always with me. So we do the technology transfer in this course with only artificial eyes, not big eyes. And we use these bionic eyes. For example, look at this. It's Ingenuity, it's 3D, it's handshake technique learning, and it's in 3D, and it's real stuff. And people are getting to know. This is the setup of the labs we have. It's normal microscope, new machines, new Ingenuity, new OCT training, learning, and all the steps you can see. And all the people that they're training, you can see Bali here, you can see people that they're coming one by one to show them what to do. And of course, you have TVRS is open to youth people. This is what I said. And the next one is going to be in August 21 to September the 2nd. And you can see how beautifully you can see in a bionic eyes the vitreous inside the eye, the vessels and everything, using all the steps. And we can do ILM removal, take lens, cataract, drop nucleus and everything. And I love to transfer knowledge now that I see so many huge surgeons coming up. So I have to say, now it's my time to transfer and to work in this field as much as I can. Thank you for accepting me, and it was great to see such surgeries and such friends.
Thank you very much. Great discussion. I think we're going to follow these great ideas. I'd like to start with Gianpaolo.
What can I say? Essentially, the points that Thanasis has touched, I think, are something to think about. We have been through similar experiences when we do our retina surgery. We find that yes, we have now given this situation a name, which is I find interesting, the zipper technique, the zipper situation or syndrome, and yes, essentially the problem of dealing with the vitreous space has always been one of the major issues for vitreoretinal surgeons, because it is so difficult to really get all that vitreous out, mostly because it is entwined with the retina itself. So you never really get all that vitreous out because it is innovated within the retina itself. So you can only get so much out. And that is one of our problems, which obviously cannot be solved. Correct? Do you agree?
Yeah, I completely agree. Actually, Jean-Paul, your comments were exactly what I was going to say. I think going back many years, Buzz Krieger taught me and all of us many years ago about how vitreous base is literally interdigitated with the retina in that area. So it's actually physically impossible to remove that tissue. And that video that Thanasis showed so brilliantly identified that area, that if you try hard to peel that with suction, you're only going to create small breaks in the retina because you can't remove it. That's why we call it vitreous-based shaving. And Thanasis, I think you've obviously shown something that we all deal with so beautifully. And for me personally, that is an immediate indication for a scleral buckle as part of my vitrectomy, because of the fact that I know that we can't get all of the vitreous out of that vitreous base, out of the attachment to the retina along that entire vitreous base. So I think that at that point, for me personally, I think you have to do a encircling buckle as part of your surgery with long-term tamponade.
A buckle would be appropriate in these cases, yes.
And my friend Thanasis, what do you think? I'll follow Tarek. What do you think about buckling these patients? I think all of us are thinking the same thing.
What do you mean, thinking of buckle these patients?
Yes, during the surgery, when you found difficulties in order to remove all the vitreous base, don't you think it's a good idea to stop a little bit and put a buckle? What do you think?
Well, I'm using some technique that it's easy for me. I'm using a 3mm sponge for a buckle. I'm not using a silicone band, a sponge. What is the difference? If you use during vitrectomy, post or pre-vitrectomy, if you use a buckle of silicone strip, 240, for example, and you try to tie it up in any case, you don't know exactly how much in a vitrectomized eye you have to tie it up. So I've seen cases when you have a ischemia because of the severe tightening, because you cannot control how much you should tie it, how much fluid you should leave inside. But with a 3mm sponge, if you put it under the muscles and you suture it, you never pull it. You just leave it there. So you suture it and you leave it, and you got the buckle that you need. You don't need just to pull the two edges to find out what it is. So you can do it anytime you like, as though, because now everybody is doing buckles with a light, with the endolumination light. They don't do buckles with the indirect ophthalmoscope anymore. So you are in the microscope, you have the light, and when you finish with the light pipe and the buckle, you just remove the buckle, because now you have the trocar, the fluid, the trocar with the valve. It's exceptionally how small things make your life easier. A valve trocar means you can put the light in, you can use it to see and put the buckle, you can remove the light out, and you can continue with the vitrectomy. You can do it before, after, but in these cases, I agree with Tarek. You should start with a buckle, and if you like, you can do vitrectomy. But people now are vitrectomy trigger happy. I've seen a lot of my fellows directly going to vitrectomy, and they don't even think about these cases. So I'm just mentioning this to see that this is a case that you can do vitrectomy and buckle at the same time. But it's very important to understand the difficulties of a situation that looks easy and it's not.
Natarajan?
Excellent, Thanasis, and I agree with you. Only thing is, I use 240 and I tighten before after doing the surgery, and then I release and have a very mild buckle height, which you can monitor during the surgery. I agree with you. You can't measure it and say how much it will be tightened, but to avoid the ischemia, I always make sure the buckle height is not very high. And in a vitrectomized eye, the scleral rigidity is differing. So if you have a mild tightening, that's good enough for a vitrectomy. But I think you showed an excellent case, and congratulations for the Thessaloniki Vitreoretinal School.
I'm looking forward, and it's an open invitation to everybody. And I would like to say that, for example, the best teacher we had this year in the School of TVRS and took the award, voting for who's the best teacher that we have, went to Tatiana Vanesova. You must remember, I saw her alive. She's not only a good surgeon, she's an excellent teacher, and use her as much as you can. But if you want to join us, please contact me by email, and I would love to have you if we don't have any more diseases, the fifth or the sixth coronavirus pandemic again. I think I've done already the third injection myself. And you can come in the last week of August. The last week of August is the most beautiful time in Greece. Of course, Tarek is always invited, and he's always busy. The only way to get Tarek into Greece is to ask him to go to Mykonos. If you ask him to go to Thessaloniki, he always finds an excuse. But you're all welcome, and join us and become teachers now in those huge people. And the young ones, they still can be teachers because they know a lot now. Technology is promoting young people because they get technology very quickly. And vitrectomy now is technology.
Athanasios, thank you very much. You are doing a brilliant work, fantastic school of teaching young people. And I think all the world recognize your brilliant work. And of course, Tatiana, that has the award of the best teacher of your course. And the ideas of you brought to us is something that we should think before start the surgery. It's not only do vitrectomy. Buccal is still alive and works very good. I love buccals, and buccals is one special tool that's continue alive for more than 50 years. But I have to thank you and move ahead because we're almost 2 hours discussing. Time is flying with so much good people. And I have to ask again, Nuti, to introduce Dr. Rupak to do the last talk.
Yes, Dr. Rupak Kanti Bishwas is done a fellowship from Shankar Chennai, awarded with the Reed Buckler Award from ASRS, also best awards from Retina and AOS. He's a great teacher and conducts Vitreoretinal fellowship. He's practicing in Kolkata. Over to you, Rupak, and you can present the video and he can give the voiceover.
Yes, sir. Thank you. Thank you so much, Dr. Natarajan, for the excellent words. And I would like to thank RWC and VRSI for this excellent platform to share today. And I'll request admin to please share my video, please. And in fact, this is an excellent, So this is a case of autologous retinal grafting in case of refractory macular hole. So next slide. So when you have a failed macular hole like this, you have a preoperative, and the below one is the postoperative after the first case, and you are really disappointed. So next, but most of the cases we do a pre-flap technique, what we do see here, and if you can just put it on, So, but most of the cases, if we do with high resolution OCT, and you can see only the scar tissue remaining into the central part. There is hardly any retinal tissue which is per se functioning. So to avoid that, so we thought that why not to put a retinal tissue per se and see how it is working. So next slide, please. Next slide. No, next slide. So this is a case of failed macular hole, where you have a pre-existing. We have measured the size of the macular hole when we were planning for this site, and we have decided to have a retinal trephine which we have devised. And that particular trephine, we have done a retinal trephination into the superior, just above the superior arcade, and decided to put that retinal tissue into the macular hole. So this is held by a forceps with the side of it, and the rest of the attachment was freed by a forceps, and this trephination was done under the saline, and when you are transplanting it over this macular area, and this is done under the air. So by chandelier, and you do a fluid air exchange in that part. So the residual fluid has been taken away with the help of a fluid needle, and donor site
was for component and prone positioning in the postoperative period. And what we have seen, next slide. Next slide. Yeah. Please click it over. Yeah. So if you can just, yeah. So you can see this was the preoperative macular hole size, and postoperatively you can see a very well placed graft here, which has somehow similar kind of architecture, which is almost matching with our normal retinal tissue, which is lying by the side of it. And this is the anatomical achievement what we have achieved. Now to see, next slide please, to see whether it is actually a functioning, that the graft is functioning or not. So next slide. Yeah, so this is if you can just put this video on. So this is a normal micro MFERG multifocal electroretinogram. We did it for these patients, and we have compared with a normal retina and the other conditions where we have a similar kind of condition. So this is a normal retina, and this is a multifocal ERG response of a patient which has been the macular hole closed by normal classic ILM peeling. This is ILM grafting, and this is by the retinal graft, where you have obviously a good spike. So this is on one platform. You can see there's a normal retina, this is a classic peeling, this is repeeling with ILM plugging, and this is the grafting area. So thank you, just to give an idea of what is going on. And this is we're doing for almost near about is more than 7 years, this technique. In between, though I have stopped some time in between, and then precisely again we are doing it routinely. Thank you so much.
Thank you so much for a great presentation and very good study of ERG in autologous graft. Dr. Anand, want to start the discussion?
Sure. I mean, excellent surgery and the discussion of concepts. Rupak, it's always fascinating to watch this particular surgery, which you have kind of championed here in India. And, I think there is a definite place for, it looks very dramatic, the surgery, but there is a place for it in, extra large holes. Personally, I feel, I would just keep it for cases where the holes are very large, chronic, and where one has already tried the tried and tested, ILM peeling, and you've already denuded the ILM of a large area, and now you're left with not many other options. One thing which I'd like to, reiterate, which I've heard Rupak also talking about, is that, the graft, the sizing of the graft is fairly important, because that needs to be about 30% more than the size of the hole, because when you bring that graft onto this hole, it shrinks. So it tends to shrink. So you need to size your graft accordingly. And that's where I'd like your comment. When you have a trephine, do you have it as a one size trephine, or do you have a flexible, bore trephine where you can adjust it according to the OCT measured macular hole size? So that's one question for you. And then, of course, I think very importantly, it's not just, just filling it and stuffing it with neural tissue. We've gone ahead and showed functional improvement. It's important to be able to assess this, not just anatomically. Sometimes when you see grafts, you find that there is a sort of uniform drill effect, complete, loss of integrity. But in your cases, I could see some of the cases that you could make out that progressively the anatomy, the structure was still preserved, and it translated into functional improvement on your ERG. Another way of assessing it would be using microperimetry to see if there is a large created scotoma, or the patient is not perceiving their scotoma and recovering functional vision. It's a great case. Your thoughts about that sizing of the graft, Rupak, and then we'll move over to our other panelists.
Yeah, I think Anand, Anand, you are absolutely.
Go ahead.
I think Rupak is on two screens.
Yeah, Anand, you are absolutely right. I think this is what you are told is that's what I was talking about. No initial phases. Then I was not considering this the graft shrinkage. So initial cases, first 2-3 cases, I had a subretinal migration of those graft. There's a shrinkage and graft loss. So then I have realized what wrong I was doing. So I have increased this to 50 to 20% of the graft size, and then it is adequately fitting into it. So this is exactly what we are doing now. And regarding Mitrifine, we have a series of from 400 to 1200 as of now, of every 100 micron size of the whole series what we have now. So we can choose among one of them according to the preoperative size.
Tatiana, do you want to make comments?
We also had a question about how to measure the correct size. Thank you.
Yeah, that is the crux of this, because majority of the cases where the autologous retinal transplant, so majority of the cases you have a bigger size of the retina, so and then you put it over that area. So here the crux is here you can just have an end-to-end touch, so that you can have an aberrant regeneration between the nerve fiber. When two cut end of the nerve fiber is put together, they have always a chance of regeneration. And there is sufficient proof that when you put it of this autologous retinal transplant, that they have a good vascularization of those areas by Octa. I think there was some publication by Dr. Homa on JAMA.
Yeah. Another point I'd like to add is that, when I do it, I kind of keep PFCL right up to the edge of that area where I'm doing the graft. And then I usually, two things again, I usually use the laser spot to make that, that cautery, that I use a laser rather than diathermy, which tends to cause you lose the orientation. Sometimes it flips over and then you're confused as to where, which part to implant. So you just rip off the last tag and then drag it down the contour of the retina and then just gently place it inside the hole. So that's one way of doing it. I think you mentioned you do it under air completely. I usually prefer to have a PFCL.
Yeah, as you have described. As you have described it. Correct. So as you have described, that is probably the easier way of doing it, and the less chance of losing the graft. But that I don't do it in that particular two reasons. One is because anyway the photoreceptor is less compared to the macro area. This is the superior retina what you are taking. So when you are dragging it, there is always a chance of more amount of the photoreceptor damage. Number one, and number two, once you put this PFCL. The residual PFCL or the surrounding area of this liquid perfluoro area, the concept is that the aberrant regeneration is touching of the clear-cut nerve end. So I don't want any material hindering in between those two. So that these are the two reasons I don't use PFCL for these cases.
Really, really great, Rupa. Great case. I learned a lot, but we just crossed 2 hours. We need to end the section.
I know.
Just one question.
Okay.
Well, Tamer Mahmoud, doesn't he knows what you're doing? Because Tamer was the one that showed me how to do grafting, even for AMD or for big holes. And he just showed that even upside down retina can be regenerated on the top. So direction doesn't, I don't think it has a lot of problem to direction the flap to put it on side. But my question always is the kind of machine you have. Is it something that we can have also, or is just for you?
This is for the commercial purpose. We are just planning to take it out, and still it is in the evolving stage, sir.
Okay, keep my email and send me big ones, because we have very big holes here.
I will love to do that, sir. I will love to do that.
Do it the same way that you did it. It's very difficult.
Sure.
Thank you. Congratulations again.
Thank you so much, sir.
Congratulations. I'm very happy with this section. We have a truly enjoyable section. I did many of this section during the year, but this one was very special with the experience from the big India, the whole Europe and Brazil. And I think everyone learned. We got many greetings for different countries like Peru, Bangladesh, Indonesia, Bosnia, Herzegovina, US, Brazil, Greece, and many India, and many other countries. And many questions I could not answer, but I promised to try to send some answers for these questions. And I'd like to hear the end words of our president, Dr. Tarek.
Well, thank you, George, and really thank you to all of you who spoke today and discussed these great cases. I'm really amazed at the quality of these cases and the thought behind them and the surgical skill with which you were able to accomplish your goals and really teach us all such great things. And so, from the bottom of our hearts, the Retina World Congress thanks the All India Ophthalmologic Society, the Vitreoretinal Society of India, Bravas, the Brazilian Retina Vitreous Society, and certainly EVRS, the European Vitreoretinal Society, and the Thessaloniki Vitreoretinal School, Thanasis, which I will promise you that I'm going to get there again to Thessaloniki. You all did brilliantly, and we thank you. The world thanks you. And your cooperation in spreading this educational initiative around the world is so vital. And I think that we do good for ourselves to get to listen to each other and talk to each other, but certainly the rest of the world and engaging across the globe. So again, thank you all very, very much for your participation. And George, do we have any announcements about anything coming out?
Just thank you. Nuki, go ahead.
I just want to thank you, George and Tarek, for the opportunity given to Vitreoretinal Society of India and All India Ophthalmic Society. Thank you, RWC and Debbie.
Yeah, thank you from Vitreoretinal Society. Thank you, George, Dr. Tarek, Dr. Mauricio, Dr. Natarajan, who's always been inspiring. Said that Thanas, it's been wonderful having all of you. It's been brilliant to be part of this session.
Thank you from the European Vitreoretinal Society, and we hope to see you soon at our next meeting, all face-to-face, no longer on webinars only. Thank you.
Sure. Thank you. Okay, everybody, have a wonderful evening, afternoon, and morning and day. Bye-bye.
Whatever.
Thank you all for this.
Have a safe stay.